Thank you for the introduction. Almost sounded like I wrote it myself, because I did. Good morning. First thing off, just no disclosures of any financial conflicts. I have nothing to sell. Maybe that's kind of foolish. Maybe I should be, but otherwise, a few days a week, I am involved in clinical mentoring or teaching students in a small clinic in a suburban part of Los Angeles. One day a week, I'm at the outpatient physical medicine rehab clinic at the Veterans Administration Hospital. And for those of you not familiar, that would be military veterans. And then whenever possible, I'm somewhere in or on the water, as I hope to tomorrow to head to Bali and do the same thing. What I'd like to do in this short period of time is to go over a little bit about spinal manipulation, what it is, what it isn't, where it came from, who does it, and then we'll look at some of the findings that suggest its potential neurological implications. Some of you, let's see if I can get my video to play here. Uh-oh, there we go. Some of you may have had spinal manipulation as a treatment and others may not have. And those who haven't may have some misconceptions about what it's like, but I'm sure it's not quite that, not quite like that. What is it? What is spinal manipulation? It is, according to the definition by the United States National Institutes of Health, something where a clinician or practitioner uses hands to apply a generally rapid movement or thrust to spinal joints. We'll go over why that might be done and what its effects are, but that's just kind of it in its most simple definition. It is sometimes identified by how it is billed. So in some schemes, in some places where insurance is accepted, it is designated by something like this code, current procedural terminology, CPT, as we call it, 97140. But that's kind of a broad umbrella that includes several things. There are other codes as well. But again, done to the spine where there is some restricted motion. Where did it come from? It's probably something that just kind of arose throughout human history, throughout healthcare systems all around the world. There is a textbook that no longer exists that's several thousand years old. We know it existed only because it's referenced in other texts, such as some of the texts in traditional Chinese medicine make reference to a specific TCM book on manipulation. This I learned a few years ago when visiting a hospital in Shanghai, where I was given a tour and ended up speaking at the university there. But it's also arisen in places in Europe. It's likely something that's just been done, other types of hands-on treatment. So it's pretty pervasive all around the world. We're talking about hypothetical ideas on what spinal manipulation might do to the neurological system. And I think the first question would be, well, is it even plausible it does anything? You might think of it as being something that is just, it might stretch joints or stretch muscles or cause a little increase in blood flow, or like a massage, just kind of feel good. But there are studies that have been done, and there's some basic science research. This is actually from a 1975 scientific conference on spinal manipulation, where a prominent Japanese researcher, Akio Sato, his work, which is often used to kind of help describe the plausibility of the effects of acupuncture on different organ and other systems, because he found that stimulating, and most of his studies were animal studies, stimulating certain parts of the animal caused either inhibitory or excitatory responses in various organ systems or different parts of the animal's body. And those same mechanisms appear or potentially underlie what happens with manipulation. Now, I said that manipulation was applying a force to the spine, but it's not quite as simple as this particular video clip suggests, although maybe in some instances that might feel good too. before I go on to describe some differences of manipulation and mobilization, I have to say that although there are people who may have a particular complaint and get a manipulation and have an immediate benefit, most people who apply manipulation as part of their treatment don't do it as a standalone, this is, the only thing you ever need. Generally, when you consult someone who incorporates manipulation in treatment, they're going to take a history. They're going to look at vital signs. They're going to rule out what we might call red flags, things we might say, maybe you shouldn't be here. They're going to assess the patient to determine what's the most likely source of the problem. They're going to also look at other perpetuating factors, psychosocial factors, sleep, stress, exercise, and incorporate potentially those into the treatment or make appropriate referrals to collaborate or coordinate care. But I'm going to just focus on manipulation pretty specifically as if it were all by itself, but rarely is it all by itself. So we have on the left-hand side mobilization, on the right manipulation. They are cousins, but not the same. Mobilization usually is a treatment is done within the passive range of motion. Manipulation goes beyond that passive range. Let me just, if I move my wrist and bend my hand back, that's as far as I can go in my active range of motion. If I apply pressure, now I'm going into the passive range of motion. Mobilization would tend to, let's assume that I could only go this far. That means, and I pushed on it and said, oh, that's restricted. The mobilization might attempt to gradually get that joint to move further and further. A manipulation would find that same restriction and try to quickly move in that direction. That's at least one of the distinguishing factors. So there's not a thrust in mobilization. Where there is, we call it a high velocity, low amplitude thrust in manipulation. There is generally not a click or a pop in mobilization. There can be, and there often is in manipulation, but there doesn't have to be. And we grade it. Manipulation is usually called grade 5 versus what's in mobilization. In my profession, the chiropractic profession, we generally refer to manipulation as being an adjustment, and we are looking for abnormal movement, and then we are taking the joint into what's called the paraphysiologic zone in that rapid movement. Being careful not to go past what's called the anatomical barrier, which would result in injury. Definitely something we don't want to do. Most people who seek manipulation seek it for pain, and typically back pain, neck pain, and a variety of headaches, particularly headaches known as cervicogenic or headaches of cervical origin that often respond or have an origin in something in the upper back or the neck. Some people do find that manipulation also makes them feel better globally. They sleep better, they feel less stressed, they have other things that they just find make them feel good. Some seek care for that initially. Most find that that's kind of a side effect as they get treated for a painful condition. But back pain is the leading cause globally of years lived with disability. Neck pain is the 4th leading cause of years lived with disability. So it doesn't seem as, I'll say, as sexy as a lot of other disorders or diagnoses, but it's pretty important. And it is, research has shown that it's effective enough, and it is included in a variety of guidelines. This is an example of the American College of Family Physicians guidelines for low back pain, which has manipulation being one of many things that are helpful for acute, subacute, and chronic back pain. And there are other guidelines. This is just a list of a few, including World Health Organization guidelines for spine pain that include it, but there are numerous other guidelines. About 75% of the chiropractors are in the world or in the United States and Canada. So this is where the statistics come from, that profession is the most likely one to apply manipulation. But around the world, chiropractors are around the world, but they're not highly prevalent in many countries. But there are people in virtually all healthcare systems who are likely going to be providing manipulation. This is just a list of some. I would say that having experienced Thai massage, that the manipulation that I experience is sometimes seems to be just kind of routine and applied as part of the massage. And I would distinguish that from what we are trying to do in healthcare professions, where we're trying to identify abnormalities and apply the manipulation there. And there is some argument that some studies that have shown lack of effective manipulation, maybe because it was just applied kind of randomly and not necessarily to areas that had a problem. But that's another talk for another time. I've talked enough about this. I'm going to see if I can, my apologies. One of the early models, and this is something from the chiropractic profession, but there were concepts very similar to this in medical professions hundreds of years prior to the chiropractic profession. But the basic idea is that the autonomic nervous system is kind of segmentally associated with various levels of the spine. And so an early concept was that these areas of the spine that were abnormal, that chiropractors refer to as a subluxation, which is not to be confused with a partial dislocation, as the term is used in medicine, that those could affect organ systems and organ health. And that is not necessarily something that has been demonstrated as being factual at this point in time. Again, there may be some plausibility to it, but no, not something that's there. This slide, as busy as it is trying to show some of the different ideas that have been postulated for manipulation. Some of the, like over here, there was an assumption that maybe there was what we'd call a fat pad or a meniscoid that was trapped in the joint. And by manipulating the joint, you freed it up, the joint moved better, and the patient didn't have any pain. Interesting idea. No evidence really for that. Some people felt that it was just a gate control theory, a gate control response, that essentially you were introducing a novel stimulus that essentially just the nervous system didn't experience pain as much because you just had new input into the area. That's still certainly possible as being part of it. And anyway, I won't try and go through all of these. Let's just say there are many, many different hypotheses on how it works. Most of them have tried to look at how it might impact pain, although there are some on the prior slide that suggested that it has neurochemical effects, including responses in inflammation. But most of the studies, because most people seek care for pain, have been on pain. And just last week, I attended a presentation by a colleague from the VA. Tina Wang is a physical medicine rehabilitation specialist at a different VA than the one that I'm at. She is a specialist in fascial pain, but she has a concept on pain that suggests that manipulation may impart mechanical changes to the fascia and create changes ultimately that are perceived and signaled through the dorsal nerve root ganglia of the spinal cord. Again, a hypothesis. I'm going to use, not because it is correct, but because I think it's a hypothesis that much of the research tends to support, one that is postulated by Heidi Havik from the New Zealand College of Chiropractic. She's a chiropractor and has a PhD in neuroscience. I am not a neuroscientist. So when I explain a few of these neurological phenomena, I'm going to give you a really low-level view because I can't explain them in a high-level view. I'm interested in the findings, but don't ask me for the details. But simply put, Dr. Havik's approach looks at what she describes as an interruption in sensory motor integration. That there are internal sensors, we call this the interoceptive input, things that are internal perceptions your nervous system has. And then there's extrasensitive, which is output, your vision, your sense of smell, taste, etc. Those all feed into your nervous system, and your brain and your spinal cord, your nervous system essentially have a clear source of communication, which leads to you having normal muscle strength, coordination, control, proprioception. Her concept, and some of the research we'll talk about in a little while, her concept is that these abnormal movement patterns in the spine essentially disrupt the normal function of the spine and the brain to have a clear and accurate communication. And this ends up impacting adversely motor control, proprioception, coordination, and going out on a limb. She feels like there are some other, when I say going on a limb, there's not much evidence for it, but also adaptability, functioning, and well-being. Dr. Habig is doing some studies on manipulation and patients' perception of quality of life, because many of those things are pretty hard to measure. But mostly we're going to focus on the neurological. But that is essentially what she's looking for. So she is, again, looking at these changes in neuromuscular function. Some of her research has looked at changes that occur both in the spinal cord and in the brain. She has done or cites quite a bit of research that also suggests one of the things that happens after manipulation, let's say of the neck or cervical spine, is that there are immediate and corresponding improvements in strength in, let's say, biceps or wrist flexors, or if it's in the foot, in muscles in the foot and ankle. But if the manipulation was rather in the lower back, that there would be changes in the lower extremity and strength. So that is one of the things. So let's go over just some of the studies that have been done, and we'll just give a high view of some of these here. There are both spinal but also supraspinal mechanisms. So we're talking about brain activity that is altered with spinal manipulation. And a question that is kind of posed in this is, and this is an important one, are these changes related to the spinal manipulation itself, or is spinal manipulation through some other mechanism improving the patient's pain, and as a side effect, there are changes in the brain? Because there are other things that can also make brain function in patients who are in pain better, and that could be anything that gets them to be out of pain. So that is not necessarily addressed by these responses here. This is a particular study that finds that there is inhibition of temporal summation of pain at the spinal cord. So it is suggesting that pain signals, so to speak, nociceptive signals, can be interrupted and there's less synaptic activity after spinal manipulation. So that suggests at least that there is a direct impact on the nervous system. That was referring to spinal cord. This is a review study that suggests that there is evidence that there are some direct changes in the brain that are neuroplastic, and also, well, anyway, they're listed there. I won't read them out. But again, an important consideration that's raised here is these changes appear to be observed. Do they explain the clinical findings of reduced pain? And I think at this point, the answer is we're not quite sure. In this study, there's a assessment that manipulation has an impact on something known as the default network mode. Those of you who are neuroscientists in the room are going to likely know what that means reasonably well. So again, the suggestion is that changes in that default mode network might be proxies for manipulation having a direct impact on pain. And again, this is a study that suggests, so this is one where there was induced pain from capsaicin, which is a substance derived from hot peppers. And the findings here were that manipulation had an impact on the experience of pain, even from topically applied capsaicin. So it's having some effect on the nervous system. But again, it's the nature of exactly how that's happening remains to be determined. Now, Dr. Weber, who's the lead author on this, is a chiropractor who also has a doctoral degree in neuroscience. He works at the Veterans Administration in one of the Northern California locations. He's also a researcher at Stanford University. And his study suggests that spinal manipulation may have an impact on something known as a neurologic pain signature. The neurologic pain signature is a phenomenon that has been identified through functional MRI that is assumed to be an objective measure of pain. Now, when we have patients who are in pain, we rely on pain scales. We give them a scale of 1 to 10. We show them smiling faces and frowning faces. We have a variety of ways. There's nothing we can put a patient's finger in and say, oh, I see, I know what your pain is. And I'm not suggesting that we're going to be doing these, functional MRIs anytime soon, but the fact is it appears to be an objective measure and manipulation appears to have an impact on it. So again, kind of an interesting finding. And this is a study just from 2026 that suggests that in patients with low back pain from a disc herniation, there are neurological changes as highlighted here, including some I mentioned before, like the default mode network. So there definitely is some intriguing information on that. If we go down to another region of proprioception, this is again an older study from Dr. Havik, and she is looking at some sensorimotor integration changes that occur based on her assessment of muscle spindle responses after manipulation. Same study. This was a study that was done military members who received one manipulation and then were required to do a very complex motor task. And those who underwent the treatment did the task with greater efficiency and speed. 5 treatments did not have show any impact. The effects appeared to be short-lived. An interesting thing I can use as an experience I've had is I have treated professional beach volleyball players and surfers at competitive events. And also several of my colleagues work with the US Olympic team, and athletes, particularly elite athletes, often seek manipulation before competing, many of them saying, I perform better when I am manipulated. Is it because they're just more flexible? Well, being more flexible isn't really a good component of, not every sport needs flexibility. So it may be that some of these proprioceptive or motor changes that occur, or that we believe occur, have an impact in the short run. If you're out to, and some of them would come in and be treated right before they went out to compete. So just something to consider. This is not a study of manipulation, but it is one of low back pain that suggests that perhaps interference in these proprioceptors are a reason for abnormal motor control and ultimately pain, which again just kind of fits into that model that I had described earlier. And this is a study that was not really looking at pain, it was looking at various intensities or amounts of force that were applied and measured at muscle spindles, again, showing different responses to different kind of forces of manipulation. So again, evidence of changes, but still not necessarily evidence of why they're having an impact. Now, going back to that one chart I showed earlier with the spine and all the organs, this would be an area that for many would be quite interesting is, are there ways that these treatments can affect more systemic health? So here's an article that suggests that heart rate variability, and just in a grossly oversimplified term, heart rate variability are kind of some of the measured, let's say, differences between each heartbeat. And greater heart rate variability is generally assumed to indicate more a healthier state and more parasympathetic dominance lower heart rate variability tends to be more sympathetic dominant. Now, obviously, you need both parasympathetic and sympathetic coordination. But if you're in a constant state of sympathetic overdominance, that would generally be something I think we look at as being not good. So this is suggesting that spinal manipulation enhances heart rate variability. So it's like, oh, that sounds like it would make people just potentially feel better and be healthier. And there have been a few studies of manipulation, particularly of the cervical spine, that have demonstrated fairly substantial, equivalent to as good as medications for blood pressure. They've been fairly small studies, and but this article here is kind of exuberant in saying, hey, this should be a part of treatment for people with hypertension. So sounds good. However, we have another study that looked at the quality of many of these heart rate variability and blood pressure studies and said, these really weren't very good studies. And in fact, we really don't know. So I think that is kind of where we're left. If we go back to this particular hypothesis, we really don't know what the clinical ramifications are. There does seem to be good evidence that manipulation has an impact on spinal cord, neurological, and brain neurological processes and functions. But we are still left with an intervention, the manipulation, and an outcome. Again, generally people seeking pain treatment and saying, I am better. And in the middle, there's a box, and we're still not quite sure what's inside the box. So to answer my initial question, what are the neurological findings or effects of manipulation? They appear to be many, but we still do not know the full ramifications. So the story is to be continued. If any of you are interested, you're certainly welcome to contact me. Here's my email.